Okay, well done.
Thank you. Okay, so welcome everyone to today's webinar series in the CARP series that we've been hosting over the past few months. It's really nice to see so many of you join the call today. For those of you who don't know me, I'm Sarah Brown and I head up the CARP early phase programme here at the Leeds Clinical Trials Research Unit. Just before we start, just a little bit of housekeeping. We are filming or recording rather the webinar, and we will be posting this on our YouTube channel after the event, so you can access this later on if you do wish to do so. So we'll record the talk and the Q&A session. If I could ask you all, as standard practice, to keep your mics muted throughout the talk. You're welcome to have your cameras on if you would like to. If you want to raise questions then or ask questions rather, then please do so using the raise your hand function. I think there is, that's from Teams, isn't it? There is a function in in Zoom to enable you to do that, or post the questions in the chat and we'll be able to pick those up at the end of the session. So today's webinar is going to focus on patient and public involvement in clinical trials research, and we've got an excellent lineup of speakers for you today. So first of all, Holly Schofield is going to be talking to us about public and patient involvement and engagement at our trials unit in Leeds. So Holly is acting PPI lead at CTRU, and she's really driving forward our policies and working groups in this particular area to ensure that all of our trials fully incorporate the PPIE in a really meaningful way. So after Holly, we're going to hear from Sandra Quinn, who's the Health Services Research Manager at Myeloma UK. Her work and research informs the way that myeloma is treated, managed, and it shapes patients' care in the design and delivery of clinical trials research. And then finally, we're going to hear from Franco Kovalchuk, who's a member of Myeloma UK's Patient and Carer Research Panel. And he's going to be talking to us about his experiences of being involved with that particular panel. So I'm really excited to hear from everyone today. So without further ado, I will hand over to Holly.
So hi everyone, I'm Holly Schofield. So I'm Senior Portfolio Coordinator at the Leeds CTRU and acting PPIE lead, as Sarah has explained. This is for maternity cover, but ordinarily I am Deputy Chair of our PPI working group and have a funded element as part of my role as Portfolio Coordinator to support PPIE activities as well. So to kick off, why is PPIE important and what is PPIE? So I've included here the NIHR definition, which is research being carried out with or by members of the public rather than to, about or for them. So this definition acknowledges that patients and the public are experts about their own lived experiences, and we could make assumptions as researchers if we don't include their perspectives. Involving patients also fosters greater trust and better relationships with the public around research. Some people prefer to separate involvement and engagement. At CTRU, we've chosen not to, as we see some clear overlap between the two. By public involvement, we're referring to patients and the public who are actively contributing to the development, conduct and sharing of research. We don't mean patients and the public being research participants. And by engagement, we're referring to the wider public conversations about health and research. And both involvement and engagement work best when they're a two-way collaborative process. So all activities are an opportunity to share what we do and receive public input. So why is PPIE important? Why do we need it? So there's the impact on research. So meaningful involvement can increase the quality and relevance of research. For example, it can help to ensure that research meets the needs of the people it's ultimately aiming to help, and ensure that trial designs limit participant burden and optimize recruitment and retention, and that study results are shared in an accessible and impactful way. There's the policy and funding argument. So PPIE is a requirement of many health research funders, and the university also has an engagement strategy which states that all research projects should include appropriate activities. And there's the moral obligation. So patients and the public have a right to be part of decisions which ultimately are going to have an impact on their care and lives. And this is particularly important given that much of our work is publicly funded via taxes or charitable donations. So I've included this slide to help frame what is successful PPIE. These questions can help ensure that public involvement is beneficial to the research and to the individuals and groups involved, and that it's a positive experience for public contributors. So is it ethical? Are you supporting your PPI contributors sufficiently? It can be really daunting for new PPI reps to be like thrust into an environment of academics and clinicians and trialists. And it's really important to acknowledge that and to tailor how PPI is conducted to meet people's needs, to talk to them and learn about their concerns and adapt accordingly. Being clear and transparent with PPI contributors about decision-making processes in research, how exactly is their input changing research, what ideas weren't you able to implement and why? And whilst formal ethical approval isn't normally required for PPIE, it's important to that we use an ethically conscious approach to PPIE. So research ethics are intended to protect the safety, dignity, rights and well-being of research participants. And the same principles apply in PPIE. We need to consider the impact of PPIE processes and shouldn't run activities in a way that compromises people's safety, dignity, rights or well-being. And Sandra is going to demonstrate how this is achieved in practice in her talk in a while. Is it meaningful? So PPIE can be tokenistic and a bit of a tick boxing exercise, which fails to have significant meaning and impact on research. And inviting a PPIE contributor to a steering committee or a management group won't mean an awful lot unless they really do feel able to contribute in a meaningful way. And to include meaningful PPIE, we need to ensure that patient input has significant impact on the research, that the ideas are listened to and those voices are heard and considered. Are you involving the right people for your research and who has the relevant experiences? Meaningful PPI will have considered what you're asking and why. And the ideas and opinions received could be the difference between a study which succeeds in meeting patient need and is acceptable to patients and one that isn't. Is it inclusive? Thinking about the diversity of your PPI contributors, are you including harder to reach groups and communities? Their experiences may be quite different and this will ensure that those aren't overlooked. It also helps build better relationships with healthcare in these communities and ensure broader and more representative research. Again, going back to that flexibility and adaptability in PPIE design and making sure that those methods of involvement and engagement can meet people's needs, identifying potential barriers and putting in place solutions that so that a broader range of individuals from various backgrounds and circumstances are able to contribute, and developing a culture of sharing and empowerment of patient voices. So I've included a slide here on the UK standards for public involvement. So these are designed to improve the quality and consistency of public involvement in research. They were developed over 3 years by a national partnership, and the standards are a description of what good public involvement looks like and encourage approaches and behaviours that are the hallmark of good public involvement, such as flexibility, sharing, learning and respect for each other. I think I touch on most of these areas throughout the presentation, so I'm not going to go into too much detail here, other than to say that they're a really good tool for all types of research with public involvement to help with planning PPIE activity, and I would highly recommend referring to them. So I've included here the research cycle to stress that early involvement, early PPIE input into research is really key, and to also maintain this throughout the research process from beginning to end. And of course, the earlier patient involvement begins, the greater chance it will have of being meaningful. The earlier you can involve PPI partners, the greater the potential benefit for recruitment and retention of trial participants. Even if something doesn't seem like it directly affects patients and is kind of more behind the scenes, for example, using existing data sets or doing a systematic review or lab work, PPI is still relevant if the outcome has the potential to affect patient care and treatment or healthcare policy. And these questions, and there are still questions to be asked that benefit from the patient perspective, particularly around relevancy. and they can really help shape a vague or early stages idea into clear research questions and aims. So here's some examples of PPI activity at various stages in a study. I think Sandra's going to go a bit more into this in her talk, so I'm not going to go into too much detail here, but as well as stressing the importance of early involvement, another aspect that can sometimes be overlooked is at the end of a study in dissemination. So PPI contributors can advise on dissemination strategy, advise on how to feedback to study participants, publicise findings more widely to the public, but they can also be co-authors on papers or present at conferences. Sorry. So at Leeds CTRU, we have our PPIE working group, and this was formed in 2019. The working group review and improve LICTA's strategy, infrastructure and processes. And we're really aiming to help build capacity and confidence around PPIE, and that includes improving support for public contributors, reviewing processes and communication, and to help contribute to engagement initiatives. And the group has members from different divisions and roles within the trials unit, and we had 2 public contributors who joined our group this year. And one of the first things we set out as a priority for the group to look at was to review our existing policy and guidance and to update this. And we had the updated documents were released earlier this year. So our policy sets out to outline our commitment to PPIE, but it doesn't advocate a single approach. It more outlines the minimum standard that we expect within our research. And our guidance is like a more detailed and provides lots of suggestions and considerations to help trial teams meet the expectations that are outlined in the policy, but also think about additional things that they could do to improve PPIE in trials and at a broader scale. So I've taken this extract from our PPIE policy to show that each study has a named PPIE lead and they're responsible for developing a plan. But these are the sort of basic things we expect as a minimum that each trial should include. I wanted to draw attention to the ones that are in a bit more of a bold font, to say that, you know, Leeds CTRU works with chief investigators to develop a trial from initial discussions and prepare for a grant submission. And studies need to include a minimum standard of PPIE when they're thinking about that. We want to know, have public contributors reviewed your research questions? Is the research focusing on the right areas from a patient perspective? And do you have evidence of that? I also wanted to draw attention to budgets, because PPIE obviously needs to be costed into grant applications. So a plan for PPIE activity needs to be considered at that grant development stage to ensure that the budget is appropriate. Also, a little plug for the NIHR Research Design Service, as I'm an advisor for them, that they do offer a £500 grant award for researchers who are preparing for a grant application for any PPIE costs, working up to that. Oh, sorry, window in the way there. So public involvement, obviously identifying, prioritising research ideas and the need at the start of the research cycle that I've already touched on. But I also wanted to mention study design and ensuring that study design considers patient perspectives in participant burden. For example, is what we're asking people to do reasonable, and how can we limit the burden we place on people? Recruitment strategies, when, where and how would people like to be approached, and what might put them off or encourage participation. Outcomes, so what outcomes are actually meaningful to patients and their families, and when, where and how should outcomes be measured. And monitoring, and things like side effects and compliance and how these are monitored. I've also included some examples here from the CART portfolio. So the CART steering group has a PPI member who reviews expressions of interest and advises on portfolio strategy. The Promise SRC has PPI representation who have input in the oversight and delivery of studies from a patient perspective. And all MUK-CTN studies and Promise have used public contributors to review patient-facing documentation such as patient information sheet, consent and lay reviews. So just a quick note about lay summaries, and this is I've included this due to my work as a PPI advisor for the Research Design Service, because often I see lay summaries that still aren't for a lay audience, and they're still including a lot of unexplained research terminology, even if the clinical terms themselves have been defined. And lay summaries should be very broadly understandable. Research panels often contain lay members, and so they should be written as simply as possible while still communicating that research backgrounds and design. And I think reading age tools can be really helpful in assessing the complexity of the language in your lay summary. But the best thing to do, of course, is to ask public contributors to review your lay summaries prior to grant submission to check that they will be understandable. So those questions from the start of the presentation: is it ethical? Is it meaningful? Is it inclusive? I'm looking at how we can address these through 4 areas that you can see on the slide. So in terms of accessibility, thinking about things like the location of your meetings, if you're doing them remotely, the technology you're using and making sure that that's accessible to people, the timing of the meetings, whether your public contributors need any extra assistance or adjustments, whether they'd like to be accompanied by a carer or personal assistant, really trying to think about identifying the barriers and speaking to public contributors about what those barriers might be and solutions. And communications, what are the preferred methods and style of communication? The importance of language is not just important in the plain English or lay summaries, but throughout all communications and shared documents. So remembering that people may use different language to talk about study design. For example, rather than talking about outcomes, they may tell you about what they hope to gain from past treatment or what information they use when making treatment decisions. So it's thinking carefully about how you present information during PPIE activities and not assuming that public contributors will have prior experience of research methods or processes that are being used. Being mindful of jargon and acronyms and making processes as transparent as possible. Even experienced public contributors won't be quite as engrossed in research culture as staff who work on clinical trials every day, and it's just bearing that in mind. And then in decision making, being transparent about parts of the research which can't be changed and explaining why. For example, if we have a limited ability to change a research question or design when applying for a commission call, or we can't edit the wording of validated outcome measures such as a quality of life questionnaire, is being honest about those things that we can't change. Public feedback might challenge us to do things differently, and we should be open to that challenge. And when comments lead to changes, it's good practice to feed that back so that people can see the impact they're having. I think that's really important to public contributors to know that they're having that impact in the work that they're doing with us. And then in terms of supporting public contributors, I think at Leeds CTRU, we say that we should have a nominated contact so people know who to contact with any questions, but also having an induction process and providing them information from the start on things like details of payment and how they can claim expenses, details of their role, what support and training they'd like or what they can expect, information about the institution and funders, information about the study and the background to date, project timelines, and why you're approaching them and why the PPIE is important. It can also be good to have preparation and debrief meetings, so offering additional conversations on an individual basis. And this provides that opportunity to identify support needs, which they might not feel comfortable communicating in a group setting. It's also ensuring that those individual needs are met. And so having an induction process is most appropriate when you plan to have an ongoing relationship, when the public contributor will have an ongoing relationship with the research team. And people who are involved in more of a kind of ad hoc way or attending a one-off meeting, it's likely to require less preparation. However, it's still important to consider what information they might find helpful before events and how to support them more generally. And when approaching people and developing activities, it's important not only to consider people's health experience, but what other skills they might bring. For example, some people might be confident public speakers, or others might feel comfortable reading and commenting on long documents. So it's taking that time to get to know your public contributors, particularly if you're going to be working together over a longer period of time, and having those honest conversations about what activities they enjoy, trying to match with what roles best suit their existing skills. I think momentum is also worth mentioning. So that means keeping in touch regularly and providing updates and checking in between meetings to maintain that relationship. Confidentiality, it's important to discuss how confidentiality will work within specific PPIE activities. For example, do your public contributors want to be named on documents related to the study? Is there any research sensitive information that public contributors need to keep private? That kind of thing. And peer support. So how can you build in opportunities for peer support? For example, having more than one public contributor on a group or committee, or providing space at the start of a meeting to get to know each other and to build those relationships. And training and development this can not only help build confidence with their involvement and knowledge of research, but it can also be a form of reward and recognition if there's a particular aspect of research they're interested to learn more about, for example. And it could be through external courses, or it could be a session delivered by the research team. And Sandra's going to talk a bit more about some examples of available training for both public contributors and researchers in her talk. So finally, how to find your public contributors. I think which perspectives are relevant to the research topic is a thing to think about firstly, and to think broadly, who else might be affected beyond the obvious recipients of a treatment. So it could be patients, current, past, or potential. It could be patients with other diseases. It could be people who use health and social services. It could be informal carers, parents or guardians, disabled people, members of the public who are potential recipients of health promotion programs, or organisations that represent people who use services. And there are numerous ways to find your public contributors. It could be through clinical contacts, which gives that direct access to local people with the experience of a specific condition or intervention. But a thing to bear in mind here, I think, is some people may feel pressure to say yes if it's coming directly from someone involved in their care. And so it's important that they're approached in an ethically conscious way. It could be through existing public involvement groups or networks. There might be an advantage here is there might be mechanisms in place to help support people during their involvement. And experienced public contributors are likely to have more research knowledge than the average person. And I think this can be helpful in many circumstances. However, there also might be times when you want to seek a more general public perspective. It could be through local support groups. Community organisations are likely to have links to a broad range of people, and not just people who are already interested in research. But a thing to bear in mind is research might not always be a priority for those organisations. Advertising opportunities to the general public through posters, newspapers, social media, and doing it that way, you can sometimes reach people who would otherwise not think to get involved in research. But it also takes a lot of work to build up a following on social media. So you won't get the reach you need unless posts are shared from accounts with that relevant audience already established. And last on the list, but by no means least, I'm just including it last because it links so nicely to Sandra's talk, is through charities. And charity representatives often have existing knowledge and experience of research in that area. And an advantage of charities such as Myeloma UK is that they can really help with all these methods of recruiting public contributors. And Sandra's going to talk a bit more about this. So that's the end of my talk. Thank you for listening. My email address is there if you need to contact me for any reason or have any questions. Thank you.
Thank you, Holly. That's really great. So I think perhaps, unless anyone has any questions of clarity, I think maybe if we move straight on to Sarah's talk, and then we can take questions to all of you as a panel, if that's okay. Great. I'll hand over to Sarah, to Sandra, sorry.
Okay. So can you see my slides? Is that right? Great. Okay.
Yeah.
So thank you, Holly, and to Sarah. So the Health Services Research Programme I lead on aims to better understand the needs and experiences of people affected by myeloma and their related conditions. And as part of my work, I also lead on patient and public involvement for the charity. Myeloma UK seeks to deliver our work through four key cornerstones. And these include diagnosing myeloma earlier, discovering and sharing knowledge, transforming the patient experience, and influencing positive changes in care. As Holly has already alluded to, it is vital that the patient and carer voice shapes and informs the research landscape, as the outcome has the potential to directly impact their lives. The quote here from the NIHR beautifully demonstrates this point. They suggest that patients with their lived experience of diagnosis, disease, and treatments have a unique set of skills and knowledge that are of equal importance and value to the academics of developing and carrying out the research. Myeloma UK is committed to achieving this through our PPI activities and patient and carer research panel. The panel itself consists of patients and carers affected by myeloma and their related conditions, and has been operating for 5 years. In order to volunteer for the panel, potential members need to fill out a quick online form, and on joining the panel, each member is asked to fill out a quick survey so that we can find out more about them and the kinds of activities they want to engage in and why they want to do so. This helps us to match panel members up to the research requests we receive. Our members are at different points in the cancer journey, and this is beneficial as it allows us all to capture important insights into the rich tapestry of lived experiences of patients and carers. So what kinds of patients and carers are on the panel? We currently have 51 members registered on the panel, and as you can see, we have roughly equal numbers of males and females on the panel. We have more patients than carers on the panel, and whilst we receive a larger number of requests for patient input, we also want to ensure carers have a voice in the research landscape, as they often know just as much, if not more, about what happens during the patient's journey. And they can therefore offer important insights. The current diagnosis of our patients is shown in the table. Some of the panel members have more than one diagnosis and therefore fit into more than one category. It's worth noting that many of the myeloma patients have previously received a diagnosis of MGUS and/or smouldering myeloma and can therefore talk about their experiences throughout the diagnostic pathway. Patients in the panel are at a range of time points in terms of their diagnosis, which is useful for a number of reasons. Clearly, we have patients that can talk about receiving a diagnosis in the last year, whilst others can reflect on how things were over the last 10 years. We also have patients that can talk about new treatment pathways and their outcomes, whilst others can reflect on different lines of treatment that they have received. In developing the panel this year, we have also increased the number of younger members to ensure we capture a wider range of potential experiences and opinions. We also have new members on the panel from different ethnicities, and we aim to develop this further to ensure we have a breadth of experiences and views. So why then do people join the panel? This is a quote from one of our panel members. And in explaining why they joined the panel, they reflect on their desire to keep up to date with new research and to help other people in the same situation as them. Other panel members recognise the importance of the patient and carer voice and the added value they could bring in terms of their lived experiences of their myeloma. Others want to give back to the research community and offer their support to benefit themselves and other patients. As Holly mentioned earlier, effective PPI requires patients and carers to be involved in the whole life cycle of a research programme, from the initial ideas through to the outputs produced throughout your work. When we asked new members which activities they were most interested in, they clearly indicated a wide range of interests that cover every part of the research journey. These included advising on study designs, including clinical trials and surveys, joining advisory boards, including clinical trial advisory boards, and also completing studies and reviewing study documents. This demonstrates how much our panel members want to be involved in every step of the research process. We can therefore tailor our members to each part of your research activities, and by building relationships with our members, we can find the right match for your work. In 2020, we undertook a review of the panel to find out how we could better support our members to engage in research. Our panel told us that they wanted clearer instructions on what they were being asked to do, to know why the research was being undertaken, and the objectives of the research. They also wanted to know how much time it would take to actually be involved in the work and any deadlines that you might have. As a result, we have developed a new set of processes. Once you send us an email for support and a request to engage the PCRP, our Patient and Carer Research Panel group, we ask you to answer some straightforward due diligence questions. These mirror the issues raised by the panel and include some others. As with all research requests, it's up to the panel members to decide whether or not to engage, and all of the activities we promote are voluntary. As part of the process of collecting this information, we also ensure that panel research requests are ethical, meaningful to the panel, and inclusive, which is obviously key to successful PPI. And once we've reviewed your answers, we send these requests out to our panel members. In the last 12 months, we've received 28 panel research requests. And whilst most of these have come from the UK research community, international researchers have also engaged with the panel. And we've been approached by PIs, early career researchers, including PhD students, and other national cancer organisations. When we look at the types of research requests we've received, it's clear that patients are engaging in most of the research life cycle. As you can see in the pie chart, a large proportion of our requests are around joining advisory boards, surveys, and clinical trial design, and reviewing study documents, amongst other activities. But this doesn't necessarily cover the totality of potential PPI activities that our panel can engage with. I was recently delighted to see an invitation to our members to feedback on a grant application and a separate request to provide feedback on a journal article that was about to be submitted for review. Whilst I think all of these activities are important, I think we can actually do more. Patients can be included from the outset, where there's a seed of an idea, and sit alongside you as part of the research team throughout the whole research journey. Providing feedback is also an important part of engaging with the panel. For example, we may ask you to tell us what has changed or improved as a result of the panel's input. I can then feed this back to the panel members, and this also ensures the panel understands how their contributions are shaping the research landscape. Here are some of the examples of the kinds of feedback we have received recently. In some cases, the feedback we've received from research teams has demonstrated how engaged and informative the members' opinions have been. Other researchers have described what has changed as a consequence of the panel's feedback. In this case, the researcher mentions improving their information sheet as a result of the panel's feedback. This feedback ensures potential participants can understand what is expected of them and may increase the likelihood of more patients and carers joining your studies. This example shows how the views of panel members have changed the design of a study and reduced the burden on patients. Clearly, a study design may be great on paper, but not necessarily work for patients. And by listening to patients and carers' voices, and by ensuring the study designs do not produce a significant burden on patients, researchers can maximise their recruitment and reduce dropout rates. This may assist you to speed up the progress of your research, the impact it may have, complete the study earlier, publish your results earlier, and in doing so, ensure benefits from your studies, improve the lives of myeloma patients and those with related diseases at pace. We can also publicise research studies, and we have a similar due diligence process for these requests. Some of these requests have increased engagement in your research. Whilst raising awareness of a new study in our e-newsletter, over 1,000 of our subscribers clicked on a link to the research study to find out more. We also have close links with the support groups in the UK and can engage with them to take part in research and disseminate new studies. Other opportunities include social media, and our social media posts alongside these other methods ensured that we at Myeloma UK had 2,000 participants take part in our COVID surveys. This obviously reflects our ability to engage with a wide range of patients and carers across the UK. And we can also provide support to researchers for grant applications as well through our support letters. There are a range of PPIE activities, a range of research resources that can be used and training opportunities that you can use to learn more about PPIE. Some of these involve modules that you can undertake on your own and written resources to support you and also PPIE members to undertake these activities well. And some of these include best practice examples as well. Before I go on to introduce one of our panel members, I would like to summarise by saying that we would really encourage you to come to us earlier and to our patient panel earlier, because we have a wealth of experience in this space, and we in our panel can help you to include patient and carer voice in your research so that you can generate patient-centred research questions, support you to develop your research and ensure participation throughout the life cycle of your programme of work. I'd now like to introduce you to one of our panel members who has kindly agreed to join us today. And I'm pleased to welcome Franco, who has been a member of the panel for 1.5 years. So over to you, Franco. Can you tell us a bit about yourself, why you became a member of our panel, and what your experiences have been?
Okay, no problem. I'm a member of the panel as a patient rather than a carer. So I was diagnosed with myeloma 3 years ago, which came as a bit of a shock. It was a disease I'd never heard of. I had no idea what it was. I didn't realise it was a blood cancer. All I knew was at the time I'd been experiencing severe back pains in my lower back, and that's all I thought it was, and that's all I was encouraged to think it was by medical experts who were seeing me at the time. It took several weeks for someone to work out that there was something more going on other than a bad back. After a series of scans, they detected the myeloma and also detected the fact that one of my vertebrae was actually fractured, which was the reason for the back pain. This was a classic symptom of late diagnosis myeloma when the symptoms haven't been picked up in advance. So the first stage for my treatment was to get some radiotherapy to stabilize my back, and then start on a course of physiotherapy to learn to walk again. That was run in conjunction with 6 months worth of chemotherapy. And then once the chemotherapy was over, I was then put forward for an autologous transplant, a stem cell transplant. So there were lots of stages involved in the build up to that transplant, most of which were worse than the actual transplant itself, and very distressing in some respects. And then a period of a few weeks in hospital for the actual transplant. And what the transplant involved was taking some of my own bone marrow out and keeping that on ice until the transplant date, then giving me a shot of some very toxic chemotherapy, which would destroy any bad cells within my system, and then feeding the old bone marrow back into me to make it repair all the damaged tissue. And then after that, I went into remission and have been ever since. So things not looking too bad at the moment. And so the reason why I joined the panel was because I wanted to make full use of my remission period. And I decided that I wanted other people to kind of benefit from the experiences I'd had, which were not necessarily always great. And I wanted perhaps to make things a little bit better for the people who came after me. So very much a case of using my experiences for positive change, as some of the other speakers have mentioned, as a reason of having PPI, and hopefully can contribute to future research in the case of people who are putting forward research proposals as described in some of the other talks, and give the patient perspective on that. So I've taken part in quite a few of those kind of things. I also want to perhaps help with the campaign to improve early diagnosis, as in the case of my own diagnosis, where things didn't happen according to plan and things happened very late, which caused an awful lot of pain that could probably have been avoided had somebody spotted the symptoms earlier. And also very much a case of raising awareness of what myeloma is and what the symptoms are, because they're quite hard to spot even for a very experienced GP. I was very lucky that eventually one of the GP I was with at the time did actually have a suspicion that that's what I had, even though he didn't mention it to me. He put me forward for an MRI because he was very concerned about the symptoms I was displaying. And also one of the other reasons why I wanted to join the panel was because I was quite keen to engage with other people who had myeloma. I had no idea what this disease was, so I had to learn all about it during the process of my treatment and the time that came after. And I wanted to meet other people because I had the same thing, because I felt that they would understand better what I'd gone through than well-meaning friends and family who had been there through the treatment process. So I very much wanted to engage with somebody who understands in that respect. And other things I've been involved in as well are contributing to clinical trials, and also I'm part of the study that's looking at the relationship between myeloma and COVID-19. So I give regular blood samples to that project, which enables researchers to see how somebody in my position might react to COVID-19, or what the effects of having had the vaccine, as in my case, having had the vaccine twice, and whether I've got the prescribed number of antibodies that can perhaps show some sort of immunity for people with myeloma. So why did I want to be on the panel, and what have I contributed since I've been on there? So again, the thing I think I've benefited from most as a panel member is interacting with other people who've got myeloma, and I act as a volunteer on a blood cancer charity forum and engage with other people with different kinds of blood cancer as well as myeloma, and give them the benefit of my experiences and hopefully benefit from some of their experiences as well at the same time. And it seems to provide some sort of closure for people who have had similar experiences and didn't realize that there are other people out there who have gone through the same thing, and find it a comfort to find other people who have gone through something quite as terrible as they have. So in terms of what I could provide in terms of a service for researchers, well, I think that's been touched on by the other speakers very much in the human and the patient side of things. And you can design the best research proposal in the world, but if you don't know the perspective of the person who's going to be affected by the research that you're doing, then there's a missing link somewhere in there. But if you can get that perspective, it makes it a strong proposal, I suspect. And also, I think one of the things is that by feeding into research proposals, clinical trials, and other research related activities, it helps to provide a future where the quality of life for people like me is better than it might have been otherwise. So I went through in total a year's worth of treatment, and I fought very hard to get my life back to a point where it was as normal as it was ever going to be, much like it was before I was diagnosed. So I treasure every day that is what I would call normal, although that's been heavily disrupted by the events of the last year or so. I really like having days where things are normal and I can do things and go out and do things. So that to me is another value to me, and also to provide a perspective for people who may be going through research proposals as well. So that's me, and I hope that's not too painful for everybody involved and of some use to all of you. I'm happy to take any questions as well.
Thank you, Franco, for taking the time to share your experiences and views with us. If you want to know more about the panel and how we can support you with PPI activities, please do get in touch with us via email at research@myeloma.org.uk. You can also find out more about our research activities by visiting our website at myeloma.org.uk. Thank you very much.
Thank you, Sandra, and thank you, Franco. That was really, really interesting and very thought-provoking. And I know I've got a few questions. So I'd like to open up to questions to Holly, Sandra, and Franco. So I can see, so please do put them in the chat or raise your hand. I can see, is it Leslie? Got your hand up?
Yeah, thanks to Myeloma UK, my husband was diagnosed in 2003, and thanks to Myeloma UK and the then CEO, Eric Lowe, I found myself embroiled in all sorts of PPI activities, from funding streams to the NCRI-MUK group and the myeloma subgroup of SAME. I also served on the NICE treatment pathway for myeloma committee, and after that on the QSAC, the quality that looked into the what's been decided. And I'm now on the trial management committee of MUK-14, I think it is. I can't remember. It's got a fancy name that I can't remember. And I would just like to say that PPI isn't just nice. Oh, I've also served on the executive committee of Involve. And can I just say to Sandra, you need to take that off your slide, sweetie. It's now the CED, not Involve, but the stuff they've got is the same. It's this engagement department that's taken over from Involve, which has now been dissolved. So it needs to come off your slide, sweetheart. I just think that it isn't just a nice thing to have. It's absolutely essential, because your PPIers are the ones who will get the idea from the bench to the bedside, check it on every bit of the way, and make sure that it is patient facing. And I think that's probably the most important thing that I've learned over all the years. Unfortunately, David was diagnosed with 2 years to go, and he lived 9. He couldn't have the stem cell transplant, Franco, because on the frailty scale he was too frail. But Myeloma UK are the most fabulous group of people, and they're so dedicated and so helpful that the journey was difficult but helped. And I want to thank them publicly now for that. Thank you.
Thank you, Leslie. That's really nice to hear. I'm sure Sandra will echo that.
Yeah, thank you very much. And it means a lot to me and the organisation that we are helping so many patients and families to live well. And I take your point about involve. I think I included it simply because they still have some slides that are useful for researchers, but I take your point on that one.
Yeah, actually, Sandra, I think you'll find the slides are disappearing on the 30th of this month.
All right, okay.
And then they'll all have to go to the CED for the information that they need. But I just think that for such a rare cancer, to have a group of people so dedicated and so well versed in everything that's going on is unusual, but absolutely brilliant at the same time. And as for that bunch of people in Leeds, well, all I can say is they make really, really, really good coffee. So thank you, guys.
I hope we do some good trials as well, Leslie. Anybody else got a question? Oh, Lisa, I can see that you're waving your hand, Lisa. You're on mute, Lisa.
Yes, it's not, I can't keep my mouth shut, can I? But I would just like to endorse what both of the last speakers and Franco said about Myeloma UK, and just to say how important it is at a first diagnosis that patients and carers are guided towards the local support groups, because those are absolute lifesavers. I came to mine, which is at Leeds, run by Rita Rumsey, who's absolutely superb. 4 years, I was smouldering for 4 years, and nobody, my diagnosis, put me into in contact with anybody. So I was floundering around, and I actually came in contact with her at one of the myeloma days that are run around the country, where people get together from the area, and that was so important for me, and it was like a lifesaver. So it's how you actually get newly diagnosed patients and carers pointed into the direction of your local group. And I think if we could get nurse practitioners and consultants more aware of saying, you can go to these people. I know that myeloma supports the actual body is there, but to actually be given a name to someone that you can talk to, and the buddy system they have is brilliant as well, both the formal one and the informal one. I'm actually 6 years post stem cell. Myeloma's raised its head above the parapet, and my paraproteins are rising. So I dare say that further treatment for me is on the horizon. But at least I know what to expect now, and not sideswiped because of lack of information. So that's all I have to say. Thank you.
Thank you, Lisa. So we've got a couple of minutes left, so maybe I'll just take chair's prerogative and just ask one final question. Franco, it's really good to hear about all the different ways that you've been involved in research. I just wondered, from everything that you've done, have you picked up any themes and things that perhaps we could do better? And if there's too much, just say so.
No, I think the main theme is something that has already been targeted, which is to get diagnosis earlier. That seems to be something coming through from a lot of people that I've been in contact with that have had myeloma, and certainly in my own case, and really with such an obscure disease and such a disease that most people have never heard of, and the symptoms are quite difficult to spot as well. it's absolutely vital to try and get that diagnosis in earlier rather than end up with a broken back like I did and have to do it the hard way.
Thank you, Franco. I appreciate that. Okay, so I just want to say thank you to all our fantastic speakers today. It's been really interesting. I do have other questions and things I'd like to ask you, which I will do offline. What I would say is that we're really hoping to be able to host a patient day over. It's likely to be next year now when we can have a face-to-face meeting, but to just showcase some of the research that we do through the CARP portfolio and to present some of the results to you. And we'll definitely be in touch, Sandra, to involve the panel in doing that. So just to thank everybody for attending really today. To highlight, the slides will be made available on the YouTube channel. We do have another 2 webinars scheduled in the series, the next one in July, where we're going to hear from Chris Parrish and Charlotte Paulin around their experiences as early career researchers in getting involved in clinical trials research. We're going to take a break in August for the summer, and then in September we're going to hear from Andrew Hall about implementing novel phase 1 trial designs in our clinical trials. So thank you everybody, thank you to the speakers, and I hope you have a lovely rest of the week.